Okay, and here we go. So the slides in the recording will be available to you. Live attendance is required to receive the CEU credits. And to claim the CEUs, we will be sending out a follow-up email that will have that evaluation. Please respond to that evaluation within the next week or so. I know the holiday is coming up, so we'll give you a little bit more time. And then we will send you those certifications. And then also the PSU Institute on Aging will be doing an additional follow-up with a survey, and that will give you a certificate of attendance. And that's for just seeing what you learned, getting some other topics of interest, and letting us know how we're doing at the Behavioral Health Initiative. So go over the overview of the Older Adult Behavioral Health Initiative. It was started in 2015 by the Oregon Health Authority, and 24 specialists are assigned to one or more counties across the state of Oregon, and they are contracted and co-located at community mental health organizations. And we address the unique needs of older adults and people with disabilities with behavioral health needs. And we engage in collaborations and coordination in the systems of care. We help build knowledge capacity through free workforce development trainings and community education. And we also provide complex care consultations. And so if you have clients that are not getting their needs met with repeat interventions, we're able to help do system navigation and do some referrals to help out with that. So if you want to learn more, the website for the Oregon Behavioral Health Initiative is down here. You will get these slides, so you'll be able to have those. And then also, I just wanted to introduce the other Southern Oregon behavioral health. Here today, we have Linda Jones, also with Josephine County, and we have Janine Greenwell with Jackson County. We also have another advanced care planning workshop that's going to be coming up, and that one is specific to the LGBTQ community. It's going to have a lot of the same information as today, but it'll have a frame, a lens to talk about maintaining sovereignty through our end of life and after death wishes. Okay. There we go.
And it is my pleasure to introduce Angela Franklin. Angela is an older adult specialist with Josephine County and Options for Southern Oregon. She's also the suicide prevention coordinator for Options. Angela is a practicing deaf midwife and has worked with elders as a caregiver, a hospice volunteer, and a community educator. She's dedicated to making sure that people in her region have access to resources, receive appropriate support, especially vulnerable populations, including elders and LGBTQ. She is a resident of Southern Oregon for over 10 years, and her passion for outreach and education shows in her advanced care planning classes, which she holds regularly. She's a founder of Crossroads Community Death Care, which is a community-driven organization based on practical death care, education, outreach, and community grieving support. She also has training and background in end-of-life support, herbalism, grief care, funerary planning, and she regularly teaches workshops in death care, advanced care planning, shroud making, and various other folk arts. Welcome, Angela. We are so excited for your presentation today.
Thanks, Linda. Let me get to here. Okay. So, yeah, we'll get to the next slide. So we're going to today talk about advanced care planning. And a lot of people, when they think of advanced care planning, they think of advanced directives. And what I want to talk to today is about the whole of advanced care planning and to really look at it as more than just filling out a few forms. And so we want to look at advanced care planning as exploring what matters most to the person and for the person. We also want to talk about the conversations that are needed with appointed decision makers and with family members. And then we're also going to go over the various forms and documents that you can fill out when we're talking about our end of life and after death care decisions. And so why is advanced care planning important? So advanced care planning provides support and pathways for knowing and honoring one's end of life wishes. It provides a way to ensure that we are having person-centered decision-making or patient-centered decision-making. And it normalizes the concept of planning and orients individuals to the importance of identifying their goals, values, preferences for future healthcare decisions. And who is it important for? I know that I'm an older adult behavioral health specialist, but really advanced care planning is not only for older adults, it's important for all adults, 18 years and older. And so if someone has a sudden event, like a car accident or an illness, and they cannot make their own decisions, a person close to them would need to be able to make choices for them in those circumstances. And so we want to consider this when we're looking at advanced care planning, is that more than 90% of people think that it's important to talk about their loved ones and their own personal wishes for end of life. And yet only 30% of people have discussed what they actually want when it comes to end of life care. And this was a survey done by the Conversation Project in 2013. So why is it that we are not actually doing these conversations and making these decisions? So there are two documents that we're going to talk about when it comes to end of life wishes. And those are the Advanced Directive and POLST. And this presentation is, Oregon specific. So folks that are outside of Oregon, the language might change a little bit, but both of these documents are typically in place in all of the states. And so the first one, the Advanced Directive. An Advanced Directive is a legal document. So there's a lot of names that people use when we talk about advanced directives. People will talk about the living wills. People will say the power of attorney for healthcare decisions and advanced directives. And here in Oregon, the term that we use is an advanced directive that encapsulates both of those terms, the power of attorney for healthcare decisions and living will. In our newest Oregon Advanced Directive, it actually has both of those things, and it's really great. So every 5 years, the state of Oregon redoes the Advanced Directive, and this just happened this year. And it's been, I was really surprised and really happy when I looked at the new Advanced Directive. It has the power of attorney where you're appointing a healthcare representative to make decisions for you if you become unable to, incapacitated. It also has sections where there is a way to write down your living will. And so that is more of open-end questions about what you value in life, what's important to you, to add any other narrative that will help your decision makers and your healthcare providers to make or to better understand you so that they can make some of these tough decisions. So I'm very happy that we have this new advanced directive. You can also get a copy of this current one off of the Oregon.gov website, and it is offered in a lot of different languages. So they've done a great job for accessibility. So the next document that I want to talk about is the POLST. And this is the one that not a lot of people really know about in the general public. And I've also found that a lot of people within the medical field are not very clear. And so it's good to know exactly what a POLST is. Other states will call it a MOLST. So portable orders for life-sustaining treatment. And this is a medical order. And so this is a form that turns a person's medical treatment preferences into a medical order, and the POLST needs to be signed by a physician, a nurse practitioner, a physician's assistant, or a naturopathic doctor. It can be filled out by anyone, but it has to be signed by those providers. And so a POLST is for any adult that has a serious illness, has frailty, or is at the end of their life. So this is not something that a doctor would sign for someone who is healthy, and it's really for folks that it would not be a surprise if a medical event happened and they would have to make these decisions. So those are the two forms that we'll talk about for end of life. And then later in this presentation, I'll talk about what an after death care directive can look like. So advanced care planning is something, like I said before, that it's across the lifespan. And our conversations that we have with friends, family, patients, clients, they're going to change depending on where someone is at in their life. And so there's 3 areas that we can look at, and our conversations will change a bit. So the first one is adults who have not started or engaged in advanced care planning. And that can be an 18-year-old, that can be a 64-year-old. The next one is adults with serious illness who have potential for complications. And so that is going to change the conversation a little bit. And we'll get into that further on into the presentation. The next one is frail older adults and those whose death in the next 12 months would not be unexpected. So when we're talking about this population of folks, we're really having to bring in the POLST into our conversations. It's not just about advanced directives. We also need to really be able to educate people and get that POLST completed as well. So advanced care planning has a lot to do with exploration. And so these are some of the areas that we can look at when we're doing an exploration with people for advanced care planning. The first one is understanding a person's fears or concerns. There's a lot of misconceptions on anything that's a legal document. And so we need to understand, why would someone be afraid to put their wishes in writing and have it notarized or witnessed? And so we can help them overcome that. We also need to know what's their understanding of advanced directives and POLST. And that is something that we ourselves need to have an understanding to be able to identify that. We also need to ask what conversations have happened with healthcare representatives. One of the things that I found that is happens quite often with people is that they do their advanced directive when they do their estate planning. And a lot of times the conversations might not happen. And so even though someone has appointed someone, their healthcare representative, even in Oregon, your healthcare representative has to sign the advanced directive to accept that position. And that's really great, because in other states, that's not what happens. And so a lot of times people don't even know that they're the healthcare representative of this person. They've never talked about it. It was just a very quick, I think my best friend or my sister would be the one, but they've never talked to each other. So we really need to make sure that conversations are being made. Another thing that is really important is a person, what is their understanding of their medical condition? And how is that going to affect their end of life wishes? And so fostering communication between people and their doctors, helping people create a list of questions that they have, because not everyone that are having these advanced care planning conversations have a medical background, or feel that they're qualified to answer some of these medical questions. But what you can do is create a list of questions for folks to bring to their providers to ask. The next thing that is important is exploring a person's hopes, and also what living well means to them. And so this is when we get into the person-centered decision-making and helping people understand how, what does a good day look like for you? You like to be in your garden, you like to be around your family. So based on that, these decisions that we're making are going to shift to help them understand that if you want to be able to be at home, if you want to be able to do these different things, your decisions at end of life might affect that. And then also just to keep your representatives aware of what is truly important to you, because that's our goal. And a lot of times healthcare providers and the people that are our decision makers, they don't really understand the depth of what we need to really have quality of life when we're living with a life-limiting illness, serious illness, and whatnot. Another great thing to explore is past hospital and serious illness experiences. A lot of the things that our beliefs that we hold are because of our past experiences. And so asking someone, what's an experience that you've had of someone being in the hospital, of having to make these choices? And a lot of times people will, talk about, the last time they were in the hospital and what fears have developed from that, or what are the things that really worked. And so that we know that those are the things that we want to make sure happen again. We also want to look at cultural and spiritual beliefs. And this has a lot to do with decision making. And so not all cultures rely upon the individual to make decisions. And so we need to be aware and able to support folks that come from cultures that really rely upon the family unit to make decisions together, that might have specific people within their community that they want to involve in these conversations to really feel comfortable and to honor their culture. Sorry, I don't know if you're seeing everything that I'm seeing on my screen. So the next thing that for advanced care planning is goals of care. And so when you're looking at folks of all ages and all health conditions, there are a few things to consider. The first one is informed decisions. A lot of folks don't have any idea about the success rate of CPR. And I'm sure, you know, if you're watching 911 Lone Star or Grey's Anatomy, you know, like our cultural mainstream media representation of what happens when people receive CPR is not reflective of reality. And so we really need to make sure that we have the data to present to folks that reflects the actual situation. And I did a class once, and one of my co-facilitators, she actually studied the success rates for different TV shows, and it was like 48% of people of all health conditions on Grey's Anatomy left the hospital after receiving CPR. And the true percents are actually below 30%. And that's for a healthy individual. So we really need to make sure that we're providing information and we're providing it in an unbiased way so that we're not pushing anyone to do a certain decision, but we're just giving the information and then they can make those decisions for themselves. So the other one is if you receive CPR outside of a hospital, people don't realize that it requires to be transferred to a hospital. So, and if people want to stay at home and, you know, then they need to understand that you will be going to the hospital and you might be returning home and you might also be in the hospital receiving interventions. So the best way to do, to be informed about CPR and is to talk with your doctor about what results would they expect given your health condition and see what they say. And I don't know many people that ask that question to their doctors, but I think if we had more people, maybe we would have a little bit more informed about us personally and our possible success rate. We also want to think about severe permanent brain injury. And so this is for all ages and what that looks like, and talk about the effects of being on a ventilator, you know, talk about the different interventions that can come from that. The next area of goals of care that I want to talk about is serious illness and life-limiting illness. And this is when we need to get a little bit further into priorities of medical care and serious illness treatment options. And these are things that are related to the POLST. And so with priorities of medical care, thinking about this in different terms of if someone is wanting to live longer, if someone is wanting to just maintain their current health, and then also if someone just wants comfort. And then when it comes to the serious illness treatment options, and on the POLST form, you have the different sections. And so we have full treatment, we have selective treatment, and we have comfort focused. And so depending on which of those options that you would like to go with relating to a POLST, it needs to be stated that if someone chooses comfort focused, then that means that they're still going to be cared for, and they're still going to receive all of the, the compassionate care that healthcare providers can offer. It doesn't mean that they're going to be neglected. It doesn't mean it's going to be necessarily a painful, natural death. And so looking at healthcare agents, like I said, in Oregon, your healthcare agent actually has to accept and sign the advance directive. And sometimes, I mean, this is like the pros and cons. So the pro of that is that they have to be willing to accept the role. The con of having to actually physically sign off on the advance directive is that it's just harder for some folks to get that signature from that person. And so it could kind of delay it from happening and make it really difficult. But if your agent is willing to accept the role and sign off on that, we need to make sure that they are willing to talk with you about your goals, values, and preferences. We need to make sure that we get a commitment that they will follow your decisions, even if they do not agree with them. And this is can be very hard for people. And so it's good to have an ability to have these conversations, with someone who can kind of sometimes even mediate between the representative and the person to make sure that all of the questions are answered, it's clear. And so we also want to make sure that they can advocate on your behalf and that they can make decisions in difficult moments. So someone who will be able to understand some of the medical dynamic that they're going to be put into. And they also, if you're appointing someone who is not your close family member, then that can be a little rough. So you need to have someone who's able to communicate with your family and be able to let them know why these decisions are being made if they have not been part of these conversations. So the next thing that I want to talk about is after death care directives. And this is something that typically we don't talk about when we talk about advanced care planning, because we really, at the time of death, that's when, most folks stop and hand it off to the professionals in the funeral industry. And so why would we want to do it after death care directive? And that really, just like the conversations with, end of life wishes, it's so that we can guide and support the friends and families about their after death care wishes. And this can be kept with the other end of life paperwork to be accessible for our decision makers. And so this is something just like when you talk to people that there wasn't a lot of planning at end of life, and there's a lot of guilt, there's a lot of uncertainty on whether they did the right thing or not. And so the more that we can have conversations and pre-plan, the more we can relieve those hard feelings. Grief is going to happen no matter what. And so to help reduce complicated grief, to help make things just go as smooth as possible during these hard times, it's really would be nice to include the after death care as well. And so just like talking about the exploration when it comes to your end of life wishes, also when it comes to after death care, exploring a person's fears and concerns, and also, you know, talking about past experiences with friends and families and funerals, and asking what that was like for them. What did they learn? What are the things that they were like, I never want that to happen to me, or this was amazing and I would love for this to happen. So we also need to make sure you know, what conversations have happened with the family. You know, oftentimes with end of life and after death, you know, folks are like, my kids just don't want to talk about this. They will not talk to me about this. And so we need to be able to find ways to make those conversations happen. And I have a slide about some helpers on doing that. We also need to understand what our final disposition options are. And every state is going to be slightly different. Here in Oregon, we actually have almost every single possibility is legal in Oregon. And so I'll go over all of the different options on the next slide. We want to look at hopes and possibilities with a person, just as our end of life. We want to look at the cultural and spiritual beliefs and what traditions they've had in their families that they want to maintain and what they want to keep or not keep. And we also want to explore what support they have if they want to do something that's non-conventional, and also what services are available to make sure that it's not just one funeral home is the only one that's noted. So to really have the information so that we can provide as many options as possible so that people can really make these decisions on their own and not be given just a few choices. And so in Oregon, these are the different types of final disposition that are available. And so we have cremation, which is probably one of the most favorable final disposition in these current days. People see it as, you know, the easiest. They see it as financially, you know, accessible. And when we come to unexpected, tragic, you know, deaths, cremation is, you know, seen as a very easy way. The next one is called alkaline hydrolysis. Alkaline hydrolysis is also called aquamation. This is something that Oregon has made legal for humans. It's been used for animals for a really long time. And so basically this is the use of warmth, water, and alkaline solution to break down the body. And then similar to cremation, you're left with the pulverized bones. And so you can get those returned if you like, to scatter or bury, similar to the cremation. We also just last year, natural reduction became legal in Oregon. Washington was the first state that legalized this. This is known as human composting is kind of the most direct way of saying it. And this summer, it will be happening in Oregon. So there's facilities that are making, that are going to be opening, and it'll be possible. People can still, if they choose this option, they can always decide to do that in Washington. There's places right over the border from the gorge. Also, body and organ and tissue donation. So on our license, we have that is for tissue and organ. That is not full body. So there's different places like OHSU and different programs that you can learn about and fill out the form to do a full body donation. There are a lot of reasons why you would be ineligible. And so there are different ways to research that. We also have the conventional lawn burial, and that's when we're looking at like a cemetery. We have green and natural burials. We actually have a conservation burial spot outside of Ashland, up in the mountains, where it is a green burial cemetery, and called Willow, or it's called the burial forest at Willowit. And most of the older cemeteries will allow for natural burials, because that's what all of our burials were up until around a little after the Civil War. Home burials are legal in Oregon and very easy to do. You just have to own the land or get permission from the person that owns the land. And it's a pretty simple process. We can also do burials at sea in Oregon, and we have military burials. So there are a lot more options than what people will think of, either being cremated or being embalmed. And so we just need to be able to let families know. So when it comes to forms, when I talked about legal forms, so there is a legal form that the Oregon Mortuary and Cemetery Board has created for Oregon specific to appoint a person to be your after death care decision maker. And so this is important for people who, the next slide actually, your next of kin. So your next of kin is the person for your advanced directive, healthcare decisions, and this is the line of those folks. You have your spouse, your domestic partner, your adult children, your parents, siblings, grandparents, then it goes to aunts and uncles, and then to cousins, and then it goes to close friends. But you have to go through this entire list to get there. So when it comes to folks, and we live in, Southern Oregon in the rural area, we have a lot of people who maybe have chosen family over their, legal family. And so if there's any sort of estrangement, if there is any disagreement on what you want versus what your family wants of you, you can do this this form, and you can find this online, and that will appoint a person and an alternate to be able to make these decisions. And funeral homes have to follow this form. Sometimes they'll say, I need power of attorney, but this is the form. The cemetery board, their ruling body, they have to follow this. And so this is the way to protect yourself. And in the LGBTQ advanced care planning workshop that I'm doing later in July, we'll go into this a little bit more, but especially for trans folks, this is a really important document to know about, to make sure that you're maintaining your sovereignty after death. And so we're going to look at how do you start these conversations. And there's a group called the Conversation Project, and they're really great. They have guides, and I'll have their website later on. But it always seems too late, too soon until it's too late. And so these are conversation starters for advanced care planning. And so, saying like, I need your help with something, or can you and I have a conversation about so-and-so? But sometimes that, it's still hard. So when you say, I was thinking about what happened to Aunt Karen, and it made me realize, or when, when my brother died, do you think their wishes and priorities were respected towards the end of life? When you can really bring in personal stories and situations that people can relate to and really make that connection, sometimes it makes it more easier to understand why you would want to be having this conversation with me, Mom, And so that I find is a really good way to have these conversations get started. And saying, even though I'm okay right now, I am worried that my diabetes might pose some complications. And so I want to be prepared. Can you talk with me about some things that matter to me? And really pointing to the reasons why you're concerned. You have a serious illness. You have a life-limiting disease. And it's important to talk about these things that matter to me, because I don't want you to not know. And I want to relieve that feeling of being a burden. And so we want to talk about when do you revisit your advanced care planning documents? And we have the 6 Ds. And so the first one is decade. So every 10 years, I like to say when you, at 60, really making that every 5 years would be great. 2, divorce. So if there's any change in your family structure, if your healthcare representative, if you get divorced, you need to redo that. A diagnosis. So if you have a diagnosis of a chronic illness or a condition, when we think back on those 3 different groups to look at for advanced care planning, we're gonna maybe change some of our decisions and really have to revisit how that chronic illness or that condition is going to what's going to happen at end of life that is different than you originally thought. Whenever there's a decline, and that's in yourself or your appointed representative. So if your partner is showing signs of dementia, you need to consider that maybe you need to choose someone else, or for yourself, if you're feeling like there's any sort of shift in your health, just to revisit. The 5th one is a death. So this is of your appointee, your decision maker. You'll need to choose a new one. So a lot of people that are older that have chosen their spouses, if they're widowed, they're going to need to appoint a new person. Also, within that death is an experience that has changed your perspective. So there might be a death of someone and it shifts how you feel. So that's another time to really revisit. And then also distance. So if you move to a new state, so advanced directives are state by state, and POLSTs are state by state. And some states will honor other states' advanced directives and POLSTs, but it's not definite. And so it's always good to when you're traveling to bring your advance directive, a copy of it with you, or bring your POLST with you. The POLST, you know, we have it's a bright pink document in Oregon. There's also pocket-sized cards that, you know, you can carry when you're outside of the home. And so one of the things, if someone lives in 2 different states, we have a lot of folks who will like go down south during the winter time. And so if you live in 2 different states, you need to do this whole process of the documents in both of those states. If you are older and you are traveling for an extended period of time to go visit family, and you have an illness, you are frail, you are, you know, possibly have a life-limiting illness, you need to think about, maybe I want to research that state where my child lives and get their advance directive filled out and given to the closest ER, whatever hospital, you know, if you had an accident, what hospital would it be that you would be sent to? And so the sooner they have this information, the availability of it, the more likely that the intervention, you know, might work for you. So we just need to be prepared when we're traveling. So as things change in our lives, we need to revisit and change our advance directives and living wills as needed. Okay, I think I'm a little early, but we'll just either get out here early or have lots of time for questions. So these are the resources that are really great, especially for Oregon and other, actually, half of these are Oregon. So the first one, the Oregon POLST, is a great resource for providers and for the layperson. The next one is the conversationproject.org. They have lots of good videos. They have conversation guides that you can print out, and they have them for you know, various people and cultures. We also have Respecting Choices. This is the group that I am trained with, and they do advanced care planning, facilitator trainings, and yeah, are just really great at providing a framework to have these conversations, and especially facilitated conversations within healthcare systems and community organizations and at the community level. So this is something that is not just for healthcare settings. These conversations can happen outside of the healthcare setting and then move into the healthcare setting to be utilized. And then also in Oregon, we have the OregonFuneral.org. This is a huge resource of information of anything you can think of. If you're having a conventional funeral, a home burial, you know, anything, it gives so much information, and all Oregon related. And yeah, so I think that is it for my presentation, and I definitely want to open it up for questions. Linda, I don't know if you want to go through questions in the chat.
Sure, I would be glad to read them out. We started out at the top. What's a good resource if someone wants more data outcomes on CPR?
So there's a lot of good studies. There is in 2012, the New England Journal of Medicine did a trends in survival after in-hospital cardiac arrest. And so that is one of the resources that you can find. Mainly it's from different medical studies. So I can, when we send out the materials for the follow-up, I can add a few links to some of these articles for people to look at. But from what I have with some of the decision aids that I've been supplied with, so of adults who receive CPR in the hospital and they live, up to 26% will leave the hospital alive. So that's 26 out of 100. If you're a healthy person, will leave the hospital alive. For adults who are older, weak, and living in a nursing facility, CPR will be successful for 2% of individuals. So that's 2 out of 100 individuals. And that is from the Journal of American Medical Directors Association from 2007 from an article. So I'll link those 3 articles in the follow-up email for people to take a look at.
Great answer. So Megan is making a statement. Length of time for CPR is also important because people often say, I'd be okay with it once if it includes AED.
Yeah.
Yeah, as far as writing a advanced care record, I'm sure. George has actually raised his hand. You can unmute yourself if you like, George, to ask a question.
Yeah, I think I have. First of all, I I came late. I had to take my daughter to the airport, so I missed the presentation, but I see your recording. Is it possible to ever hear the recording?
Yeah, you'll be sent the recording with a follow-up email. Yeah.
Okay, now I did have a question, and which I probably did not speak on, and that has to do with the advanced directive. I did this advanced directive in 2012, and then just going over it recently, I noticed that Part D on page 6 of this advanced directive, declaration of witnesses, that I had the wrong people. I just then read has not appointed either of us as healthcare representative or alternative representative, and the people I used were both.
Okay. Are you in? George, are you in Oregon?
I'm in Oregon. Yeah.
Yeah. So in Oregon, you can do either 2 witnesses that are not your healthcare representatives, that are not healthcare providers, to be your witnesses, or you can get it notarized. So yeah.
So and is this still good? Probably this is still good then, even though it's old, because I hadn't wanted to change the healthcare representatives.
Yeah. Those directives never expire. So even if you filled it out, 30 years ago, it's still a legally binding document.
Oh, okay.
If the witnesses are correct or it's notarized. So
all right. Is it also possible, like the witnesses are here, is it possible to add 2 witnesses to this old form?
That's something that I think would probably be more of a legal advice question that I wouldn't be able to answer.
Oh, okay.
But I would take that to your bank for a notary, and maybe just get it notarized.
Okay, that's good.
Yeah, and then you don't have to worry about the witnesses being added and whatnot.
Okay, then the only other question that you might not answer in your presentation, and that is with regard to the POLST, whether right now, of course, I would like to be resuscitated. So, but I'm 87 and I have heart issues. So, what I think should I fill out one of these and hide it somewhere? And only bring it out when I'm kind of feeling sort of terminal.
No. So that document doesn't mean anything if someone can't find it, or if
Yeah.
it hasn't been submitted to the POLST registry. So every doctor that signs a POLST will submit that POLST to the registry. That's what they're supposed to do in Oregon. But if you typically they're bright pink, because
Yeah.
when you're at home and you have an event that has you incapacitated, and the ambulance, the first responders are called, they're trained to look for that POLST. So if it's not out, they won't know. And so if they don't know, they will do everything possible to keep you alive and bring you to the hospital.
So I guess my question is then, when do I put this on the refrigerator?
You can put it at any time.
Yeah, but I'm not okaying DNR now.
So for you, because you want to be resuscitated,
Yeah.
having that on your fridge is not as necessary. It's more for the folks that do not want to be resuscitated, because you are going to get resuscitated no matter what, because that is the practice that happens when the ambulance comes for anyone.
Yeah. So.
And so for you, what you want to do is have a conversation with your doctor and ask, what is my likely outcome, with my current medical condition, if I receive life-sustaining treatments and interventions, and really be informed on what that looks like for you specifically. And only your doctor is going to be able to provide that information to you.
Oh, and so he would be the one to say when to put this up.
Yeah.
Okay.
Yep.
And then the same thing goes for the advanced directive. You probably did cover this, and that is, how do I know this was going to be in effect? I mean, just because the doctor has a copy, and there's a copy here. This is not the original. The original's in the safe, I think, and my wife has a copy. So
yeah. So when you do your advanced directive, it needs to be sent in to the hospital that you would be flown to and entered into your medical records. And once it's entered into your medical records, it'll be accessible by healthcare providers. But you want to make sure that your physician has a copy, your your hospital system that you live within has a copy. You want to make sure that your representatives have a copy, and that it's known where those copies are. Because if you don't file it in your medical records, then unless your wife carries that with her in times of extreme.
Yeah, I see.
Yeah. And one of the things is that if you have the conversation with your wife and she knows what you want, if she knows, then she'll be able to tell that to the doctor, even without an advanced directive. Well, so it's important to have these conversations.
We got to have them again, because it's been, since 12. It's been 10 years since we've looked at this. So we'll look at them again. And then in my case, I have to get this notarized and resent to everybody, right?
Yes.
Yeah. So it's got to go to the doctor and the hospital, and make sure it gets sent where? To the state or something?
For your POLST, there's in Oregon.
No, not the POLST. The advanced directive.
Advanced directive is just to your hospitals and to your doctor.
Okay. All right. I thank you very much.
Yeah, thank you, George.
Yeah. Thanks, Angela. I think you would probably answer quite a few questions. So Anne just made a statement that she's 73 years old and relatively healthy, but during early COVID, she got a POLST. The CPR results are not encouraging in normal times. It was clear to me that being on a ventilator long term would not restore me to the quality of life I value. Also, it seemed that resources should be utilized for those with better survival prospects. And it's just kind of an interesting statement because my understanding was a POLST, a doctor fills that out if you have a terminal illness or you only have 6 months to live. Can you address that?
Yeah, so when you, if you're older and have some other illness, underlying conditions, with COVID, a lot of the healthcare, doctors were asking about pulse because, going on a ventilator is a serious thing. And so the doctors wanted to make sure that they would be ready in case, you were put on a ventilator. And on the POLST website, there's actually a link there that is proactive care planning for COVID-19, directly related to the POLST. So if I will remember to provide a link for that. And this is to be used by clinicians. So this is a lot of really good information on how to have these conversations related to COVID-19. And that's going to change as COVID changes. So as if we're seeing less ventilator use and whatnot. So
thank you, Angela. What a great response. I hope that it addressed any issues or concerns. Megan asks if you have any specific information on guardianship, especially if a person can no longer appoint a healthcare representative due to dementia. Maybe they haven't gotten an advanced healthcare directive prior to that.
yeah. So if you are someone's legal guardian, then you're going to be able to make those decisions for them. And you need to, if you have someone, it's just the more conversations you have ahead of time, the better. And that's a whole additional workshop, is when it comes to the loss of capacity that has to be, declared by a judge in Oregon, and the whole process of going through that and getting deemed a guardian. And so, yeah, so I can provide some information. Your follow-up emails are going to be filled of lots of links for people to go to.
Right.
And so the conversations that I'm talking about, those are either with the person who's doing the care planning for themselves. These conversations can also be happening with someone's guardian, the person who's going to be making these decisions, and exploring with them as well, because a lot of times people don't realize what all goes into making these decisions. I hope that answered it.
It sounded like a great answer. We've got a couple of people with their hand up. Kristen, if you want to unmute yourself and ask your question.
Sure, just really quick. I have tried to help people walk through the process of potentially being, you mentioned tissue donor or organ donors. I do think it's important to point out that especially in rural areas where we are out in Malawi County, that's a really difficult thing to do. There's like refrigeration needs that hit and like all these other things. So I don't know if you have resources related to that as to how you find out what that process is, because people think it's just easy, like you donate and then they come and get you or something like that. And that is not the case at all. Like you have to like purchase a refrigerated truck and have your body has to be at a specific temperature. Like it's very complicated. So there are those options, but it's pretty complicated. And especially when you live far, far away from like OHSU, where we live on the other side of Oregon, it's nearly impossible and very expensive.
I completely agree. And there's a lot of education that needs to happen around tissue and organ donation. And there are definitely resources. OHSU's page talks a lot about that. And so they have some really good links to find out what the requirements are. And so this is also something to think about depending on what type of final disposition you would like as well. You know, it is possible to do some of them, but like you said, there's a timeline. And so you have to wait until the, you know, certain things are signed off of. Only certain people are going to be able to, you know, donate certain things. And the really kind of the thing that a lot of people don't like to talk about is who is receiving these tissue and organ donations. Is it going to someone else who's on like an organ donor list? Is it going to research? Is it going to private corporations that utilize tissue to create products? And so there is a lot of information out there about, yeah, what the price of skin is. And it's really sad to think about that, you know, people thinking that they're donating their tissue and organ for the good of someone, and it's being utilized for plastic cosmetic surgeries or cosmetics. So you really need to make sure that you do your research, and if there is ability to designate exactly who receives your organs, and if you decide not to do that and you change your mind, then you need to go into the DMV and get them to take it off of your ID, because there's really no other way in Oregon to do it except going in person to the DMV and changing that status.
Wow, that's interesting. So we have quite a few questions, and here's one that I think will be quick. Doug asked, if the witnesses, do the witnesses need to read the full document, or do they just need to witness the person's signature?
The witnesses just need to witness the person signing the document. Because the notary also, if you're getting it notarized, don't sign the document until you're in front of the notary. And yeah.
Right, right. And Randy has asked a couple of really interesting questions, and one is about more information about a death doula. And maybe if you have more time towards the end, but she also asks if you have any advice about removing a medical power of attorney that was granted to a family member who lives in California while living in Alaska. It sounds like it's kind of a tangled mess. Randy, I don't know if you want to unmute yourself and for more clarification.
Yeah, that sounds a little messy.
Can you hear me?
Yep.
Oh, great. I'm not real good at this. Yeah, my husband's sister is second medical power of attorney, and I was recently in the hospital, and she very much overstepped her rights as power of attorney. She visited my neighbors. She really intruded upon my life. And so
is she your power of attorney or your husband's?
Both.
Okay, so you can change your power of attorney at any time. You just redo the document, and any new one trumps the old one. So you just have to make sure that you get it filled out, notarized, witnessed and given out to everyone that has copies of it.
Okay, great.
Yeah,
And-
so it's not permanent. I mean, it is permanent, but you can always change it.
Okay, because I
It's
know
always
she's
in
gonna get,
place. You can always change it. Yeah.
okay, we love her, but I know she's gonna give us an argument. And I just want to do it right. She's
Yeah, and
always
maybe
welcome.
having a conversation, and clarifying any fears, and like maybe having that conversation will make it clear to her, but maybe not. So then you need
Yeah.
to choose someone else.
I understand. And do you know anything about death doulas?
Yes, I am an end-of-life doula, and they're non-medical support for folks at end of life. And there's many different types of end-of-life doulas. People can I call myself a death midwife because I reach into all of the possibilities, while other folks maybe just focus on being bedside. They focus on doing life review, or focus on advanced care planning, or focus on education. So it's really, there's a lot of possibilities. And our last week's presentation was about death doulas and end-of-life doulas. So if you email me at AngelaFranklin@Options Online, I will email you the recording of last week.
Thank you. Thank
Yeah.
you very much, Angela.
You're welcome.
Great, thank you, Angela. And Kristen makes a really good point. She says, write your congressperson and Oregon Health Authority about adding death doulas to be under the traditional healthcare worker umbrella. Much like community healthcare workers, birth doulas are already recognized as billable in this way. And since we are moving more and more towards that, do you have any ideas about that? You want to make a...
Yeah, actually, this is one of the projects that I was excited to work on. And the conversations are happening. And so we do have what we call traditional health workers in the state of Oregon, and there's a registry for 5 different classifications, from peer support specialists to birth doulas. And there's training requirements, and once you get on that registry, you can get reimbursement for your services from either the state healthcare, or like individually contract with CCOs. And so the birth doulas in Oregon did an amazing job of getting onto the registry. So they've laid the foundation of the heavy lifting work. It has already been done by them. And so currently folks are looking at if we can add another classification of end-of-life doulas, so that we can embed folks, into different healthcare settings, be able to get referrals from palliative care and hospice, and be able to, get reimbursed to make it accessible to all. Because right now, end-of-life doulas, they have to come up with their own pay. And so a lot of times it's either only for people that can afford it, or end-of-life doulas will offer their services sliding scale or as a volunteer. So there's a lot of different things that are happening with that. but really excited, and hopefully we'll see them being added in the next few years.
That's great. Thank you so much. Kristen also mentioned that she did get information. This is about donors, that the last time she checked, that yes, the donor does pay, and some people go ahead and make arrangements ahead of time to include that. And Doug asks if you need a refrigerator truck only if the person resides far away from a medical school.
You know, I'm unsure about that. So if this is something that people are really interested in, maybe we can put together a presentation specifically on this. I would be happy to facilitate that happening.
May I say something?
Yes, you may.
A very dear friend of mine, her husband died up here in Alaska. He was transported from our small town of Homer to Anchorage, which is about 250 miles away. He died on his way there in the medevac, and she, I'm not sure how she managed, but she took his body, put it in her pickup truck, and drove the 225 miles back to Homer, 10 miles across the ocean to her home, and buried him in her front yard.
In different states, different requirements happen. And so home burials are legal in many of our states. It actually goes by county, the different regulations. So Josephine County and Jackson County differ than Malheur County in Eastern Oregon. So you really have to know what the possibility is. And there's lots of the Home Funeral Alliance is an organization that's national, that has a lot of good resources that folks can find, people that can help with home funerals, and it goes state by state. So those states will be able to have people. Typically, if you're a home funeral person, you're going to know about home burials as well, because sometimes they go together. So in Alaska, that doesn't surprise me. You know, some of the states that like Idaho and Oregon, we have the ability, it's very easy to do home burials.
Yeah, I thought it was fairly heroic of her.
Yeah, and you know, the Civil War is when we shifted away from family, community-centered death after death care. You know, with the bringing embalming because of the soldiers and the amount of soldiers that died, and wanting to transport them back to their homes. You know, folks brought back, you know, from Egyptian time, they brought back those methods of embalming to really preserve the body as much as they could. And it became the norm at that point. So it's really, you know, community, family-centered activities around and after death. It's only been in the last, you know, 150 years that it's shifted.
Well, thank you.
Yeah.
I'll turn off my mic now.
And we have about 9 more minutes left, so I'll answer a few more questions if there's any.
George has another question. He says that the advance directive says that I should wait to sign in front of the notary. Does that mean I should sign again for the notary, or should I just start all over with a fresh advance directive?
I think that the notary is going to be able to answer that for you. Because like I said before, that's getting more into the legal advice, and I'm not qualified or able to give legal advice. But it sounds like you're wanting to revisit it and maybe redo and to have those conversations. So to go ahead and do a whole new one and have conversations with your representatives, and then you don't have to worry about, yeah. It's all about the conversation. That is the most important thing, is relaying what you want to the people that are going to be in this position. Okay.
Okay, thanks a lot.
Is there anyone else that has any questions? Okay. Well, I really enjoyed giving this presentation, and I hope people learned about this. I will put my email in the chat. And the follow-up email will be coming from me. So you can just reply to the follow-up email with any additional questions that you have. Allison, you have your hand raised?
Yes. What is the date of the LGBTQ event?
It is July 27th.
Okay, thank you.
Yeah. Okay, well, I want to thank everyone for joining us for our series, and keep an eye out for more trainings from the Older Adult Behavioral Health Initiative and from our county. So everyone enjoy the holiday weekend, and take care. Thanks.
Great training, Angela.
You can stick around, Linda, if you want.
I thought I would.
Okay. Thank you, George. Okay. I always feel like there's a number of people that are taking naps right now, so.
So I've stepped out of the room, sure.
I'm removing people, so.
Oh, you are, okay.
Yeah. Okay.
Yay.
So was it okay?
It was super. It was really excellent.
Okay, good. I'm like, I don't know if it's like too much information or.
Oh, and I really like your PowerPoint too. Sometimes PowerPoints are so full of information that it's hard to keep track. Yours are simple and clean, and I like your cartoon version. It's softer, right? It softens a difficult topic, I think.
Yeah.
Yeah. And in the beginning, you said you were nervous. You sounded a tiny bit nervous, but as you were going, it's like you totally got into your element.
Yeah, no, that was, I think I was just like, oh, I have to do this and this and.
Right. I mean, even just sitting here, trying to monitor the other stuff. It's so
you know what? We're recording right now. Crap.
Oh.